Good morning, everybody. We are officially starting the 2020 IDoR celebrations. As you all know, International Day of Radiology is conducted on November 8th every year. And each year there will be some theme denoted by internationally by the radiology community. And this year it is COVID-19 and radiologists and radiographers' role in treating COVID-19 patients. Now, this topic, the radiologists and radiographers, I think they have put this together. Although they are two separate communities, they have put this theme together, possibly considering the fact that in a COVID-19 setup, a teamwork will always work, will be better than something like separate entities. For example, if you do an MRI or a CT, normally we don't go into that compartment. We just ask the patient is placed in the scanner, the images are obtained, and then they are sent to via PACS or anywhere into the workstations, and from there the radiologist acts usual pattern. But in certain situations, this radiologist may intervene in between. But in a COVID setup, things are totally different. You have to take some extreme personal care to manage and treat, and even image these patients. So I think the care given to patients is a combined thing by the radiologist and by the radiographers. The radiographers take the scans, the CT, MRI, and the X-rays, while the radiologist will be doing the ultrasounds and other investigations, like for example in specialized investigations coming in radiology or in MRI or in CT. So I think it is quite relevant to have a combined talk. Therefore, today we are putting the talks together. Now, what is the other side of that? Now, we all know that the radiology and all those things, have certain limit in COVID-19. Of course, only the severely ill patients show much of the radiological findings. So the early stages, of course, the clinician is the person really managing the situation, not to worsen the patient. So a clinical perspective is also really important in COVID-19 setup. It's a new disease too. So today we have got 3 speakers here from 3 scenarios. From the clinical setting, we have Dr. Fatauddin, who is the Vice Principal and the Head of the Pulmonary Medicine Department in Ernakulam Medical College. Of course, a senior chest physician. And he'll be talking, he's managing the COVID patients all over the state. Initially, he was the state nodal officer. Now he is the COVID nodal officer for that hospital and also treatment lead there. Now, he has got a bit of experience, even in Westerners and even in Indians. He has got some experience, which he will share with us. Now, I think Dr. Fatauddin is here. Pradeep is joined. He'll be joining in a few minutes. Now, from the radiologist point of view, from our point of view, Dr. Rashmi, I put Rashmi again because Rashmi is already in an elaborate way explained the COVID findings in all the patients and all CT and the X-rays and all. Now, today we will have a capsule type, a diagnostic pearls type of talk from her in diagnosing various types, various scenarios of COVID patients, the A, B, C, D. That said, now the other part of the topic, that means how the radiographers are interacting with the COVID patients. That I think Rajesh is here. I think Rajesh is from Kottayam. Is Rajesh?
Yes,
Rajesh is here? Yeah.
Yes, sir.
I'm welcoming him into this. I'm welcoming Dr. Fatauddin. I'm welcoming Dr. Rashmi, and I'm welcoming Dr. Rajesh to the Zoom, who will be starting their class immediately after our function of this. Now, along with this, I'll have to welcome my senior comparative radiologists who are working in IRIA. First of all, I would like to welcome the IRIA State President. I think the IRIA State President is here, Dr. Jayashree L. Dr. Jayashree, I'm welcoming her to this Zoom meeting. It's an IDoR celebration of Trivandrum City Chapter, and we welcome you, ma'am, to this. Dr. Jayashree? Dr. Jayashree?
Speaker mute, microphone mute.
Okay. Now,
welcome. Thank you, Manoj.
Okay. Now, we all know Dr. Pradeep is the IRIA National Vice President. The elections were over yesterday. Then the past year, we had a lot of problems with the COVID and all. But basically, it was the COVID which has created all the organizational problems, I would say. So now, Pradeep has been invited to this. He has agreed to inaugurate this function. And welcome, sir, to this Zoom meeting. Dr. Pradeep? Okay. Now, one more person is there, our CEC member, Dr. Harikumar Nair. Sir, he is traveling right now. He's a very busy man right now. He's the, what do you call it? The special officer to all new medical colleges. As you know, every district has a medical college right now. And he's traveling all around. Now, I believe he is moving towards Kasaragod. Kasaragod also, we have a medical college. Kannur, we have medical colleges. Government medical colleges are everywhere. And he's a special officer for that. So he has to go everywhere. Now he is right now traveling. Maybe he'll connect us over phone. Harisar undo? Harisar? Okay. Welcome. Anyway, with this, I would like to invite Dr. Pradeep S. for inaugurating National Vice President to inaugurate this IDoR 2020. Pradeep, over to Pradeep.
Hello.
Pradeep, yeah, you can hear you.
Ah. Okay. Dr. Jayashree.
I think I request everyone to mute their phones except Pradeep.
Hello. Dr. Jayashree, President Kerala Chapter. Dr. Harikumar Nair, Central Council Member. Dr. Manoj Pillai, Central Council Member and President, Trivandrum City Chapter. Dr. Suresh Babu, Secretary, City Chapter. My fellow colleagues in IRIA, seniors, friends and students. A very good morning to all of you. It gives me immense pleasure to be here on this auspicious day to inaugurate this webinar organized by the City Chapter. Today, November 8th, is the day of a great discovery of X-rays by William Röntgen in 1895. And today is the 9th International Day of Radiology, our own day, and let us celebrate together. As you are aware, this is a difficult time for the whole world due to the spread of COVID-19 pandemic, which has affected our lives. Today is therefore dedicated to all imaging professionals and their essential role in fighting the COVID-19 pandemic, making an indispensable contribution to the diagnosis and management of COVID patients. The motto for IDoR 2020 is radiologists and radiographers supporting patients during COVID-19. It is our duty to look back at the hardships we have faced over the past few months and recognize our contributions to the society during this difficult time. It is time to consider how the current demands are affecting radiologists and plan for the future. I am sure today's speakers, Dr. Fatauddin, Dr. Reshmi, and Mr. Rajesh will give us a great academic feast. With these few words, I inaugurate the IDoR celebrations and the webinar. Thank you very much.
I now request the IRIA State President, Dr. Jayashree L, who is also the professor and HOD of Department of Radiodiagnosis, Medical College, Trivandrum, to say a few words on this auspicious occasion. Dr. Jayashree.
Okay. I hope I am audible.
Yes.
കേൾക്കാമോ?
കേൾക്കാം.
ട്രിവാൻഡ്രം സിറ്റി ചാപ്റ്ററിലെ എൻ്റെ അധ്യാപകർക്കും സുഹൃത്തുക്കൾക്കും ഇന്നത്തെ സ്പീക്കേഴ്സിനും എൻ്റെ നമസ്കാരം. IDoRനോടനുബന്ധിച്ച് എല്ലാ കൊറോണ മാനദണ്ഡങ്ങളും പാലിച്ച് ഈ സെമിനാർ സംഘടിപ്പിച്ച സിറ്റി ചാപ്റ്ററിന്റെ ഭാരവാഹികൾക്ക് നന്ദി അറിയിക്കുന്നു. ഈ പാൻഡമിക്കിന്റെ കാലഘട്ടത്തിൽ എത്രയും അനുയോജ്യമായ ഒരു തീം തന്നെയാണ് IRIA എന്ന നമ്മുടെ സംഘടന തിരഞ്ഞെടുത്തിരിക്കുന്നത്. അതിനെപ്പറ്റിയൊക്കെ ഡോക്ടർ മനോജും ഡോക്ടർ പ്രദീപും പറഞ്ഞു കഴിഞ്ഞു. ഞാനതൊന്നും വീണ്ടും റിപ്പീറ്റ് ചെയ്യുന്നില്ല. സെൻട്രൽ IRIയുടെ ഈ സ്പിരിറ്റ്, അതായത് റേഡിയോളജിസ്റ്റും റേഡിയോഗ്രാഫേഴ്സും ഒന്നിച്ചു നിന്ന് പടവെട്ടേണ്ട ഒരു സാഹചര്യം തന്നെയാണ് ഇപ്പോൾ നിലനിൽക്കുന്നത് എന്നുള്ള ആ സ്പിരിറ്റ് അതേപടി ഉൾക്കൊണ്ടുകൊണ്ട് നമ്മുടെ ഓരോ സിറ്റി ചാപ്റ്ററും റീജിയണലായി ഈ ആഘോഷങ്ങൾ സംഘടിപ്പിച്ചിരിക്കുകയാണ്. ഈ ഓൺലൈൻ CMEയിൽ സന്നിഹിതരായിരിക്കുന്ന ഏവർക്കും സർവോപരി നമ്മുടെ ക്ഷണം സ്വീകരിച്ച് നമ്മോടൊപ്പം ചേരാൻ സന്നദ്ധത കാണിച്ച ഡോക്ടർ ഫത്താവുദ്ദീൻ, വൈസ് പ്രിൻസിപ്പൽ ആൻഡ് HOD പൾമണറി മെഡിസിൻ, എറണാകുളം മെഡിക്കൽ കോളേജ്, ആൻഡ് മിസ്റ്റർ രാജേഷ് ഫ്രം കോട്ടയം മെഡിക്കൽ കോളേജ്, പിന്നെ നമ്മുടെ സ്വന്തം രശ്മി എന്നിവർക്ക് പ്രത്യേകം അഭിവാദ്യം അർപ്പിക്കുന്നു. ഈ CMEക്ക് എല്ലാവിധ ആശംസകളും നേർന്നുകൊള്ളുന്നു. ഒരു വാക്കുകൂടി, IRIയുടെ ഈ തീം കിട്ടിയപ്പോൾ റേഡിയോഗ്രാഫർ ഒരാളെ സ്പീക്കറായി വേണമെന്ന് നമ്മൾ തീരുമാനിക്കുകയുണ്ടായി. രാജേഷിനെ സജസ്റ്റ് ചെയ്തത് ഞാനാണ്. കോട്ടയം മെഡിക്കൽ കോളേജിൽ നിന്നും DRT കഴിഞ്ഞ ശേഷം അമൃത ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസസിൽ നിന്നും പ്രത്യേക പരിശീലനം സിദ്ധിച്ചതിന് ശേഷം രാജേഷ് സർവീസിൽ കയറുന്നത്. കോട്ടയത്ത് 2 വർഷം ഞാനും രാജേഷും കൊളീഗ്സ് ആയിരുന്നു. ഔദ്യോഗിക ബഹുമതികളും പ്രൊഫഷണൽ ക്വാളിഫിക്കേഷൻസിനും അപ്പുറം രാജേഷിന്റെ ഒരു ക്വാളിറ്റിയാണ് ഈ അവസരത്തിൽ രാജേഷിനെ തന്നെ തിരഞ്ഞെടുക്കാൻ എന്നെ പ്രേരിപ്പിച്ചത്. മറ്റൊന്നും അല്ലാതെ അദ്ദേഹത്തിന്റെ കമ്മിറ്റ്മെന്റ്, ആശുപത്രിയോടും തൊഴിലിനോടും രോഗികളോടുമുള്ള ആ സമർപ്പണം. ഈ കൊറോണ പോലെയുള്ള ഒരു പാൻഡമിക്കിലെ ഏറ്റവും അത്യാവശ്യം ആയിട്ട് ഒരു ഹെൽത്ത് വർക്കറിന് വേണ്ടത് അത് തന്നെയാണ്. അതില്ലെങ്കിൽ നമുക്ക് എന്തുമാത്രം സൗകര്യങ്ങൾ ഉണ്ടായിട്ടും കാര്യമില്ല. അതുകൊണ്ട് നമ്മുടെ സിറ്റി ചാപ്റ്ററിലെ സ്പീക്കറാകാൻ രാജേഷാണ് ഏറ്റവും അനുയോജ്യനെന്ന് ഞാൻ കരുതുന്നു. എല്ലാവർക്കും ഈ സുദിനത്തിന്റെ ആശംസകൾ ഒന്നുകൂടി അറിയിച്ചുകൊണ്ട് നിർത്തട്ടെ. നമസ്കാരം.
I'll try to get Dr. Harikumar Nair, sir. Sir, can you just say a few words? Okay.
Thank you, Dr. Manoj. നമ്മുടെ ഇന്റർനാഷണൽ ഡേ ഓഫ് റേഡിയോളജിയുടെ ആഘോഷം നമ്മൾ സ്റ്റേറ്റ് വൈസ് നടത്തിയില്ലെങ്കിലും അതാത് യൂണിറ്റുകൾ നടത്തുന്ന ഈ അവസരത്തിൽ എന്തുകൊണ്ടോ സ്റ്റേറ്റ് അത് ഏറ്റെടുത്തില്ല എന്ന് തോന്നുന്നു. എങ്കിലും അതാത് യൂണിറ്റുകൾ അത് ഏറ്റെടുക്കുകയും അതായത് യൂണിറ്റുകൾ എന്ന് പറഞ്ഞാൽ സിറ്റി ചാപ്റ്റേഴ്സ് ഏറ്റെടുക്കുകയും നടത്താനുള്ളൊരു സന്മനസ് കാണിച്ചതിന് ഞാൻ ആദ്യം തിരുവനന്തപുരം സിറ്റി ചാപ്റ്ററിനെ അഭിനന്ദിക്കുകയാണ്. അതിന്റെ ഭാരവാഹികള്, സെക്രട്ടറി, പ്രസിഡന്റ് എന്നിവരെ അഭിനന്ദിക്കുന്നു. എന്നാലും ഏകദേശം ഒരു 100 വർഷത്തിന് മുമ്പ് 106ാമത്തേന്ന് വേണമെങ്കിൽ നമുക്ക് കണക്കാക്കാം ജന്മദിനം. ഈ എക്സ്റേയുടെ ജന്മദിനം ആകസ്മികമായി ഒരു അതിന്റെ കണ്ടുപിടുത്തവും അതിനെ തുടർന്ന് എല്ലാ കാര്യങ്ങളും നമ്മൾ ഓരോന്നോരോന്നായിട്ട് എടുത്തു പറയേണ്ട ആവശ്യമില്ല, നമുക്ക് എല്ലാവർക്കും അറിയാവുന്നതാണ്. ഓരോ ലെവലിലേക്ക് അത് എത്തപ്പെട്ടു. കൺവെൻഷൻ റേഡിയോളജിയിൽ നിന്നും വീണ്ടും ഫ്ലൂറോസ്, അവിടെ നിന്ന് ഡിജിറ്റൽ റേഡിയോഗ്രാഫിയിലേക്കും അതിന് പാരലായി തന്നെ പല വേർഷൻസിലുള്ള CTയും നാമോഗ്രാഫിയും ഇങ്ങനെ പലതും അതിൽ നിന്ന് നമുക്ക് നേടാൻ കഴിഞ്ഞു. ഒരുപക്ഷെ വൈദ്യശാസ്ത്ര രംഗത്ത് ഇത്രയും വിപ്ലവം സൃഷ്ടിച്ച ഒരു ഡിസ്കവറി, പിന്നെ ഇൻവെൻഷൻ എന്ന് പറയണോ ഡിസ്കവറി എന്ന് പറയണോ, നമ്മൾ ഡിസ്കവറി എന്നാണ് സാധാരണ പറയാറുള്ളത്. ഡിസ്കവറി എന്ന് തന്നെ പറയാം. അപ്പൊ ഈ ഡിസ്കവറിയെ നമുക്ക് ഓർമ്മിച്ചുകൊണ്ട് റോൺജൻ മാത്രമല്ല, ഇതിനെ നമ്മൾ ചുഴിഞ്ഞ് ചിന്തിച്ചാൽ ഇതിന് പല അവകാശങ്ങളുണ്ട്. അപ്പൊ റോൺജൻ ആണ് ഇത് പൊതു ലോകത്തിന്റെ മുമ്പിലേക്ക് കൊണ്ടുവന്നത് എന്നുള്ളത് കൊണ്ട് റോൺജനെയും അദ്ദേഹത്തിന്റെ കൂടെ ജോലി ചെയ്ത് അദ്ദേഹത്തിന്റെ ഇതിന് വർക്ക് ചെയ്ത അദ്ദേഹത്തിന്റെ ഭാര്യയെയും കോവർക്കേഴ്സും ഉണ്ട് ഇതിനകത്ത്. കോവർക്കേഴ്സും നന്നായിട്ട് പ്രയത്നിച്ചിട്ടുണ്ടായിരുന്നു. പക്ഷെ എക്സ്റേ കണ്ടുപിടിക്കണം എന്നുള്ള ഉദ്ദേശത്തിലായിരുന്നില്ലല്ലോ നമുക്ക് ഇങ്ങനെ നമുക്ക് ലോകത്തിന് ഒരു വിപ്ലവം സൃഷ്ടിച്ച ഇതിനെ കുറിച്ച് നമുക്ക് ഓർമ്മിച്ചുകൊണ്ട് എന്തായാലും ഈ ഘട്ടത്തിൽ ഒരു സെമിനാർ കൂടി സംഘടിപ്പിക്കുകയും അതിൽ പങ്കെടുക്കാമെന്ന് സമ്മതിച്ച രാജേഷിനും സാറിനും പിന്നെ എല്ലാവർക്കും ഞാൻ നന്ദി അർപ്പിച്ചുകൊണ്ട് നിർത്തുന്നു. നമസ്കാരം.
Now, thank you, sir. Now, I invite Suresh Babu, the secretary, to give word of thanks. Suresh?
Yes, good morning all. Dr. Pradeep, National Vice President of IRIA, Dr. Jayasri, State President of Kerala IRIA, Dr. Manoj, President City Chapter, Dr. Fatauddin, Professor of Pulmonary Medicine, Trivandrum Medical College, Mr. Rajesh, my respected teachers, my dear friends and colleagues. So this is a great occasion for all radiology professionals. And the theme for this IDoR 2020 is role of imaging professionals in fighting pandemic COVID-19. It's the most apt theme because we are suffering a lot because of COVID-19, and radiologists have got a definite role in supporting COVID-19 patients. And I think more than radiologists, radiographers are really involved in this situation because they come into contact with most of the patients, because patients are often referred for chest X-rays and chest CTs, and very less frequently only they are referred for ultrasound. Then only we come into contact with patients. So I think they mention more credits. So this is an apt thing. So my role is to thank all. And Dr. Pradeep, as you know, he has come, he is actually involved in Central Council meeting. So he has taken time to inaugurate the function. I thank Dr. Pradeep for inaugurating the IDoR 2020 celebrations of Trivandrum City Chapter. And I would like to thank Dr. Jayasri, State President, Dr. Manoj Pilla, Dr. Fatauddin for talking about the clinical aspects of COVID-19, and Rajesh for talking about the role of radiographers in COVID-19. I thank all the members of Trivandrum City Chapter for attending the Zoom meeting. Thank you all.
See, now we will go to our webinar proper. A few words of introduction to Dr. Fatauddin. Fatauddin is live now. Now he is a Trivandrum Medical College alumni, and he was senior to me, and he is a clinician par excellence. Now he is working as the HOD and head of the department of respiratory medicine for a few years now at Ernakulam. And during this COVID-19 scenario, he took, he took a very daring attitude in treating the COVID-19 patients. And of course, initial phases where the people were so much alarmed about this situation, even alleviated the fear of the community to a certain extent. I think Fatauddin is here. He will share his experiences on the clinical settings of COVID-19 right now. Fatauddin, welcome to this webinar. Okay, he'll come. Okay. So we'll start with the radiology talk of COVID-19.
എന്റെ സ്ക്രീൻ കാണാലോ അല്ലേ സർ? A very good morning to all my teachers, my seniors and friends. So today I'll be talking about the role of radiologist in COVID-19. So at the onset, I wish all of you a happy International Day of Radiology. So greetings from the hospitals where I'm working, Anantapuri and GG Hospital. Today, this is just a 15-minute talk. So I'll be not going into details and I'll be just going through all the points, all the main points. So today I'll be dealing with the role of radiologists in this pandemic, which why I feel that which is very important at this time. And the indications of the imaging modalities with severity scoring. These two actually I have covered in the CT chapter talk itself a few weeks earlier. So I'll be just going through rushing through the slides, and finally a few slides on the post-COVID imaging. So the role of radiologists. So what I feel is we should adapt to the quickly changing picture during this pandemic and minimize dangers to our colleagues without compromising patients' care. So the role as a radiologist is primarily to assess the severity and or impact of COVID-19 on patients who have tested positive for the virus and who are experiencing severe or problematic symptoms. So our main aim is to help the clinicians, and we are almost always a problem solver, and we help the clinicians to take management decisions. And the safety of radiology staff and the patients is our responsibility, and we have to make sure that all radiology staff adhere to the safety measures, and ultimately all the staffs and the patients are safe and secure. So why we adhere to strict safety measures in the radiology department? Because radiology department is highly trafficked with inpatient, outpatients, febrile, non-febrile patients coming across from various other departments. So radiology department is a common pool, and we have to actually make sure that there is no cross infection. So the initial screening of the all patients will have to start at the radiology reception, and the reception staff should be like wearing all the personal protective measures and should sit in a disinfected, clean environment. And the screening, as you all know, we should ask for any history of fever, any URI symptoms, any travel to a COVID-affected country or residing in containment zones, if they have a close contact with a confirmed or a probable case of COVID-19, or close contact with a person with acute respiratory illness is known, not a non-COVID-19, but being to a COVID affected country or residing in containment zones. So if any of these questions is answered yes, then the patient will be considered positive screen for coronavirus and treated accordingly. Even though this is a protocol that screening, and we have to divide the patients into corona suspect or corona positive or corona negative patients, I tell all my staff that you have to consider all patients to be COVID positive patients, because as you know, many asymptomatic carriers are there for COVID. So you should treat each and every patient as a COVID positive patient, and you have to strictly adhere to all the safety measures or all the disinfecting measures. So it is said that where resources are available, one CT by ultrasound machine should be reserved, separated for suspected or confirmed COVID-19 patients, which we know is not practical in our setup. So we have to encourage using dedicated portable radiograph or portable ultrasound machine for COVID suspected or COVID confirmed cases, and use CT scan only for hospitalized symptomatic patients with specific clinical indications for CT. So it is our responsibility to see that no CT scan is done without any proper indication. We have to do only for indicated patients, and we have to cross-check all the requests that are coming to our department. And you have to always keep a specific time for doing CT by MI for COVID positive patients. So in my hospital, what we do is we do all the COVID positive patients in the evenings after doing all the routine CTs or MRs. And this is what we follow, that a patient, we have to always use a portable machine if possible. And all the patients in the radiology department should wear a surgical mask entering and leaving the radiology department. And for the medical staff as well as the patients, we have to make sure, see, whatever mask, a surgical mask or N95, the proper fitting of the mask is very important. Because if we are wearing a N95 and it's not properly fitting, there is no use. So whatever the mask is, we have to make sure that all the medical staff, all the patients have to wear a properly fit, either a surgical mask or N95, and all the medical staffs which are going in close proximity with the patient, that is within 1 meter of the patient, should wear a eye protection. Either they can use a goggle or either they can use a face shield with a properly fitting face mask, and they should also wear a disposable fluid resistant isolation gown. It can be either disposable or it can be a reusable one. That it depends on the each hospital or each department. And you have to always wear a disposable gloves with coverage over the gown. The healthcare worker should be properly covered with before going to the patient. And regarding the environment, you have to disinfect after contact with every COVID-19 suspected patient. That is the image viewing station, the mouse, the keyboard, the CT and the MR gantries, the ultrasound probes. So before and after every patient, we should disinfect the whole equipments, and the surroundings also should be disinfected. I think Mr. Rajesh will be dealing with this disinfection more, so I'm not going into details, but it is the responsibility of the radiologist to make sure that all disinfections are done in a proper way. And regarding the personal protective equipment, unless we are not doing a aerosol generating procedure, it is not recommended to wear a full PPE, but at least we should wear an isolation gown with mask, face shield, and gloves. So the important point here that I want to emphasize or stress is that all the team members, so it's a team effort actually, all the team members should understand the disease dynamics, routes and source of transmission, and should take utmost precautions to prevent transmission to colleagues and patients by properly using PPI. And social distancing to be strictly maintained even between the colleagues. And staffs are advised to have food alone in one room. No two staffs are allowed to sit together without mask. So we know there are studies which showing that the source of infection for the healthcare workers is not from the COVID positive patients. They often get the infection from the colleagues because they are like very careless with the colleagues. They sit together, they chat together without masks. So that is the main source of infection. So in our department, it is a responsibility of the radiologist to make sure that all the staffs sit or take the food alone in one room, and no two staffs are allowed to sit together without masks. This point is very, very, very important. And all the respirators, face mask, disposable gown, that is after doing the imaging or doing a portable X-ray machine, X-ray in a COVID positive patient, it should be disposed in that area itself. That is closing the door and disposing the all these disposable items there itself. And soon after that, we should follow the hand hygiene. And donning and doffing of PPE is very, very, very important. And we should actually, the radiologist should train all the healthcare workers for the proper donning and doffing of the PPE. And patient care is equally important as that of the healthcare workers' care. And we should use a disposable bedspread. That is one person, one change, no reuse. It is used. And also ultrasound probes or cassettes are disinfected every time after the completion of imaging. And all the healthcare workers sanitize their hands before and after touching the patients, and minimizing conversation with the patient to avoid aerial spread of droplets. This is also very important. And rooms should not be used for approximately 1 hour after the imaging of the infected patient, and should be used only after proper disinfection. So this is regarding the patient care. And now coming to the indications, this actually we have covered or discussed previously also. So the indication is only for COVID confirmed patients with moderate or severe symptoms. There is no role in COVID screening. There's no role in COVID suspect. And sometimes we see COVID as an incidental finding if you are taking CT for acute abdomen protocol, but it's always better to include CT chest for all patients who are coming to the department for taking CT abdomen. So, so we should take CT only for COVID positive patients with moderate to severe symptoms. And there is something called an RT-PCR negative COVID. So if you are clinically suspecting COVID and RT-PCR is negative, in that case also we can do a CT for just confirming. So we mainly use chest X-ray, CT and lung ultrasound, out of which chest X-ray is the main imaging tool. The disadvantage is that it is not sensitive in the early phase, like you see in this case, but it is very, very important, or like it is actually the main imaging modality that we use for monitoring the progress of the patient. So in this case, you can see the progression of and it is not practical to take CT every time. So that is the main modality. And it is important to use a standardized language that I'll come to later. If you see no findings related to COVID in the chest X-ray, we give it as no pneumonia. And if you also see a chronic finding, then also we give it as no pneumonia. And if we find some interstitial markings, we are not sure whether this is COVID, an early COVID or not, then we give it as an indeterminate pneumonia. This is the same that some interstitial findings are there. We give it as indeterminate for pneumonia. Again, same, it can be a pulmonary edema or an early COVID. So in this case also, we give it as indeterminate for pneumonia. And if we find a focal pneumonic patch, it is not multifocal, a unifocal focal pneumonia, then we can give it as a focal pneumonia. It can be an early pneumonia also. So the terminology that we use is focal pneumonia. This is again another focal pneumonia that we see. And these two conditions, you have to always be very clear that if we see a cavitatory pneumonia or a lobar pneumonia, we are 100% sure that we are not dealing with a COVID-19. So these are two findings we should always keep in mind. And this is the typical of COVID now. So if the terminology that we use is a multifocal pneumonia or MP. So this is a day 2 yesterday, which was normal, but day 7 you can see multifocal consolidations bilaterally. So this is, we have to give it as multifocal pneumonia. Again, another multifocal pneumonia. So after using the proper terminology, we have to score it. So in all the imaging modalities, we have to score so that the clinicians will be knowing the severity of the disease and they will decide the management accordingly. So just divide the chest X-ray into 6, and then score 0 means no leg abnormality, 1 means you see interstitial infiltrates, 2 and 3 we see both interstitial and alveolar infiltrates, but if it's an interstitial predominance we give it a score 2, and if it's an alveolar predominance we give it as score 3, and the score ranges from 0 to 18, and this is how we actually help the clinicians. That is, if the score is more than 6, the patient needs hospital admission, and if it is more than 9, the patient most probably requires an intubation and the mechanical ventilation. So this we can just see it's predominantly interstitial findings, but here some alveolar opacities are there. So out of these 6 zones, the total score will become 8 out of 18, and this predominantly alveolar, some interstitial here. Now the total score is 14, which is actually very bad, and the patient may require a mechanical ventilation. This is how that we help the clinicians. Now coming to the findings we are all familiar with, that is the bilateral ground glassing, peripheral crazy paving, fibrotic changes with traction bronchiectasis, arterial distortion, subpleural bands. So all the typical findings we know, but this is the subpleural bands. That is, we see now, like now the peak has just, we are now in the peak of the COVID-19, and now after this we are going to see the post-COVID sequelae. That's post-COVID fibrosis in most of the patients. So this will be the thing that we are going to see. That is, in most of the patients, see this, the subpleural consolidation that is solved by forming the subpleural bands. COVID-19, and this is a typical one that we give each lobe we have to see it's assessment of the findings, and if less than 5% of the CT is of the have lines, this is again one B line, this vertical line is normal, and this we give as score 1, where we see confluent B lines which corresponds to the ground glassing, and the subpleural hypoechoic areas is a subpleural consolidation, we give score of 2, and this large consolidation we can see the air bronchogram, it's almost looking like a liver, in this we give the score as 3. So this is how we see the lung ultrasound that is towards this is severe disease, and we can actually predict the improvement or predict the worsening by just doing a lung ultrasound, which is very, very, very convenient. So we gave a maximum score of 36 because there are 12 on each. So 3 into 12 is 36, and an anterior region lung score of 4 because anterior region is the upper lobe, and upper lobe involvement comes later in the disease. So if the anterior region lung score is 4 or higher, we can actually know that the patient is going for a NIV or needs a NIV or mechanical ventilation later. So this is how we predict pre-disease to moderate disease. We see small, less than 1 centimeter consultations, we should start supplemental oxygenation. If the B-lines become confluent, we have to give them NIV. And if it's critical, because we are seeing large consultation, we have to think of starting mechanical ventilation. That's how this helps the clinicians. Now, a few slides on the post-COVID imaging, the post-COVID lung fibrosis. I have already mentioned that we have to look for these findings, that is septal thickening, subpleural curvilinear band, cystic changes, reticulations, and architectural distortion, which now I feel that now we see a lot of cases in the coming months. And a few words on the multisystem inflammatory syndrome in children associated with COVID-19. So in most of the countries where the peak has just gone, and even after one to 2 months after the peak, they see a cluster of children coming with these symptoms. That is multisystem involvement with the typical findings. So it has been mentioned as the multisystem inflammatory syndrome in children. So we have to know the difference in the chest findings from the typical COVID. So most of the children come with pulmonary edema and pleural effusion, which is very rare in the typical COVID-19. So this is how the patient, so this will be a battering appearance, a typical pulmonary edema finding that we see in these children. And finally, they may progress to ARDS, which is also seen in an adult COVID-19. And this is some finding we should always look for, because if we take a CECT, we have to specifically, in these children, we have to specifically look for the coronary artery dilatations, similar to what we see in a Kawasaki disease. This is also very common in this multisystem involvement. And in the abdomen, we see this bulky kidneys with echogenic, which is suggestive of an acute kidney injury with mild ascites, bowel wall thickening, mesenteric inflammation. We see this multiple mesenteric nodes, gallbladder wall thickening, splenic infarct, ascites. So I just included these slides because that as a radiologist, we have to post-COVID. And some neurological imaging findings in COVID-19. This also we started seeing such type of patients in our hospital. Again, to familiarize with you with this neurological manifestations. The most common is a typical, like what we see in a viral encephalitis. We see this hyperintensity in medial lobe, hyperintensity in splenium, confluent flare hyperintensities in the middle cerebellar peduncle. It's not specific. And this is one of the, again, common that we see multiple hyperintensities, not confluent hyperintensities in the white matter, brainstem, cerebellum. And one finding that I find very specific for the COVID-19 is the numerous microbleeds. That is, it's a hypercoagulable state, So it can be an isolated finding of a patient presenting with confusion or a seizure after a COVID, or maybe the patient doesn't know that he had a COVID. But after seeing this findings, if we do a COVID antibody, that will come as positive. So again, we have to familiarize with the findings. So this is one of the most common findings that we tend to see now. That is the multiple microbleeds within the brain parenchyma. This is an Adam sort of a picture that we may see. Again, another type where we see bilateral symmetrical hyperintensities in the thalamus. So these images I have taken from the radiology journal. So out of which they have found that the most common is the non-confluent hyperintensities in the white matter as well as the microbleeds. And last two slides regarding the cardiac manifestation. This was again, it is published in JACC. It is a recent journal where they're telling that post-COVID, patients may present with palpitations, and on cardiac imaging, they have found that myocardial edema and the late myocardial enhancement is very common. So again, to familiarize with those findings, we see a subepicardial late gadolinium enhancement that we tend to see in a viral myocarditis. Viral myocarditis usually see in the lateral wall, but in the COVID, they have found that septum wall and the inferior wall is the most common sites which is affected. So we have to look for the late gadolinium enhancement. This is subepicardial. And this is again another image from the ACC. So they are telling this is a normal myocardial edema with late myocardial enhancement here. And this is another patient with diffuse myocardial edema and a subtle late myocardial enhancement. So myocardial edema and a subepicardial myocardial enhancement is the findings that we have to look for in the cardiac MRI. So to conclude, we have to maintain a proper workflow in radiology department, assuring safety of both healthcare staffs and the patients. And I feel it's the responsibility of the radiologist to make sure that it is done. And chest X-ray is the main stage imaging in the COVID pneumonia. CT is used only as a problem solver and when suspecting complications like pulmonary embolism. Lung ultrasound is the choice of imaging in ICU, which helps in the management of the patient. And we should use standardized terminology and reporting formats for all patients to avoid confusion. And always give severity score, which helps the clinicians to decide in further management. And we should all be familiarized with the post-COVID imaging findings, as we are going to see more patients with the post-COVID sequelae. Thank you. I think I just gone through in a very brief.
Yeah, okay. Now we had a concise radiology overview of the COVID-19. Now we will go to the clinical setting, clinical perspective. I think Fatauddin will be back. Fatauddin is back. Dr. Fatauddin, can you hear me?
Yeah, Dr. Manoj, am I audible now?
Oh yeah, you are.
I'm just joining through my mobile phone, so I won't be able to show much of the slides. Anyway, we'll go straight and I'll talk offhand.
Okay.
Thank you.
Can you put on your video? I think at least we can see you.
Can you see me now? Video?
No, I don't think. Suresh,
Yes,
Okay, go ahead. Okay.
Yeah. So on this International Radiology Day, I profusely thank all the organizers, particularly Dr. Manoj, Dr. Jayashree, the Secretary, President Dr. Pradeep, Dr. Hariumar Nair sir, Dr. Jayashree, all for having given me an opportunity to speak about an important topic, a perplexing situation where we probably haven't seen during your lifetime. As you know, with the advent of this COVID pandemic, January 2020, we know that initially we were clueless as to how to treat patients. As of now, we definitely don't have a treatment. We are only trying to support the system. So I will just talk to you about the clinical aspects, which you must have already seen through hundreds of medias, our own updating, our clinical journals, meetings and all. So I just want to tell you about a couple of unique aspects of this disease. That is the clinical aspect for me. And till this point of time, we do not know the exact pathogenesis of this virus. This virus is a hitherto unknown virus, and its pathophysiology is different at the cellular level compared to the previous virus known to mankind. So this is a very camouflage evading virus. It has got multiple prongs and armamentarium on it to keep changing and fooling the human species on Earth. So the clinical scenario is like this. We know that 80% of the patients get exposed to the infection, they become positive, but then nothing happens to them. Only 10 to 15% of the patients go on to develop all kinds of complications, right from a pneumonia progressing to ARDS, not responding to ventilatory care and die, or many patients go into a state of hypercoagulable state and that they die of an intravascular coagulation, either in the form of a pulmonary thromboembolism, or they present you with stroke, or they usually present with what I usually call a coronary syndrome, where the patient will just be positive, no respiratory symptoms, X-ray chest clear, and the patient comes to you without any desaturation. They come to you with some mild fever and chest discomfort. You take an ECG, you will see a myocardial infarction. You will see a NSTEMI or STEMI. So this is the scenario. Or some patients just come to you with an acute pancreatitis or an acute kidney injury along with a COVID positive test. So having said that, the most commonest organ involved is lung. This is because, as you know, this virus gets actually attached to the ACE2 receptors, which is abundant in the type 2 alveolar pneumocytes. It is also seen in the myocardium, in the GIT, in the brain, and also in the endothelium. This is the most important part of this virus. This virus directly get attached to the endothelium of the blood vessels. So it can affect any blood vessels, right from your coronary arteries to your mesenteric arteries to your cerebral arteries. So that is because ACE2 receptors are abundant there also. So it gets attached, this endothelium, ACE2 receptors, and it produces what is called endothelitis. So what it produces, once there is an inflammation, swelling of the micro and macrovasculature, there may not be a big clot as you would expect in a saddle pulmonary thromboembolism or a classical pulmonary embolism. So if you take a CT chest, with contrast, you will not see a major thrombi sitting in the pulmonary arteries or its subsequent branches. But distally, microvascular capillaries and pulmonary arteries are completely clogged, which may not always be able to be demonstrated. So we know that this is a disease of hypercoagulable state. That is a buzzword. So there is always a state of hypercoagulability, which starts with the onset of your COVID positivity and lasts for 6 to 8 weeks after recovery. That is why many patients who require anticoagulation in the ICU, we recommend that they should be on anticoagulants for at least 2 to 4 weeks. And you also know that many patients in the HFLTC, while home quarantine, they're suddenly collapsing and dying. This is also due to the hypercoagulable state and is usually due to a vascular event. So I thought of showing you some slides, but we know about this virus. This virus, 10% of the patients die. So what is it that determines your the outcome of this infection? So it is essentially depends on the interaction between your immune system and the virus. And if your immune system is like a type A personality, and if your immune system reacts like a type A personality for trivial events, you overreact. So if your immune system is one where when the virus exposure causes what is called a risk dysregulated immune syndromes, where there is a disproportionate immune reaction, which actually causes release of large amount of cytokines, what is called interleukin 1, 2, 3, 6, and 10. So studies have shown that one of the most important cytokine that is playing a major role in causing ARDS, respiratory failure, and hypoxemic respiratory failure, acute kidney injury, and myocardial injuries and cardiac failure is mainly due to interleukin 6. So once these patients develop a cytokine storm syndrome, probably there is no force on earth can prevent this cascade of inflammatory events. This is the one which actually causes death in many patients. That is why you will see that even after the COVID positive test is negative, the patient goes on to succumb to the end organ damage. They develop a vascular event, they die. So at the time of death, they may not be positive. The virus has actually created its insult in the body so that the immune system takes over, and it is the dysregulated immunologically mediated organ damage that causes death. So what remains to be understood is why only in some people there is a dysregulated immune system, we do not know. Maybe it is genetically related. Is it HLA antigen related? We don't know so far. Probably more and more studies will tell us more in the coming 1 or 2 years. So the incubation period and all is very basic. I think you all know about it. So what is important is the early recognition of the disease symptoms is very, very important. Sometimes the patient will come to you with the category A symptoms, which you all know, like mild fever, sore throat, or it may go on to persistent fever and cough, which is category B. or you probably will see in the mild cases itself, you have mild category A, mild category B, and you have mild category C when the patient start getting more cough. Now, the first alarming sign is a first episode of desaturation. So any patient who require hospitalization, who's admitted with significant symptoms in moderate grade B or C, the first sign of alarm is a first desaturation. Usually, any patient who comes to you in the hospital with a history of desaturation invariably will have a pneumonic patch. You need not even take an X-ray. So this is the most important observation. So if a patient comes to you with desaturation, 100% that the patient actually had a pneumonic patch, unless in this very unusual situation where a patient is coming to you with an acute coronary syndrome. There also you can get desaturation, but usually 99% of the time, if a patient comes to you with episodes of desaturation, that means pneumonic patch has already occurred. So that is the point. So when a patient is admitted, you have to review the patient every 12 hours to 24 hours to see if a patient in the category A is going into category B or from category B to category C. Category B, you see more protracted cough, breathlessness, in addition to fever and other signs. And red flag signs, like if patient develops hypotension or increasing oxygen requirements, or obviously you see an X-ray showing increasing lesions, then this is category C, red flag signs. Patient may have hemoptysis, patient may continue to have tachycardia, high fever, cyanosis, very unlikely, we haven't seen much. But what you see is that once these patients develop desaturation, they remain remarkably conscious till the X-ray lesions reaches to the moderate level of ARDS or hypoxemia, till even if their PaO2, FaO2 ratio is something like 200, they remain conscious. They will be hypoxic, but they will talk to you. But then this is a very tricky virus, and this conscious level is definitely not matching with the internal hypoxemia and the respiratory failure that is going on. They can suddenly die. They can either suddenly die from massive hyperacute respiratory failure. Even if you intubate such patients, they may pull on the ventilator, they may not come out. Studies from all over the world and from our own experience that if you intubate, probably only 2 out of 10 will survive. Some may even require ECMO. ECMO, the problem is many hospitals don't have an ECMO. Timely ECMO is also not being instituted. And even after ECMO, the survival rate has not improved, but in fact, there was an improvement of around 30 to 40% improvement in survival. Those patients who received ECMO, extracorporeal membrane oxygenation, extracorporeal membrane oxygenation, ECMO unit treatment. So coming to the immunity part of this virus, many theories going on that there is a herd immunity, there is humoral immunity. What is important in COVID-19 is none of this. What is important is the cell-mediated immunity. For a virus, once it enters, it goes into the cell. So if your cell-mediated immunity is robust, then the intracellular viral killing occurs, because these cell-mediated immunity is memory-driven. So it is an immune memory-driven. So if the intracellular killing occurs, then you may be positive, but then you will be asymptomatic. This is the reason why around 30% of the people are asymptomatic. That the virus has entered, their RT-PCR is positive, but there is efficient intracellular killing. So what actually works in viral infection with COVID is actually a cell-mediated immunity, which is working in tandem with the humoral immunity. But humoral immunity may not be the only thing that is going to, protect you from this COVID-19 infection. That is to say that not all patients who contract COVID-19 will mount an antibody response. Many cases where we have seen, you just check their antibody titer for plasma therapy, their antibody titer is low, very low or negligible. On the other hand, other group of patients have at a very high rate of antibody. So getting COVID-19 doesn't guarantee you that you are immune. You have developed antibodies to it. And it is not antibody alone that will protect you from developing COVID-19 infection. What is more important is your robust intracellular immunity, which if succeeds in killing the virus, then you will remain asymptomatic. That is why around 30% of the patients are asymptomatic, but they can transmit the disease during the initial 3 to 5 days. These patients are infectious 2 days prior to the presence of symptoms to 5 to 7 days after the beginning of onset of symptoms. By around 8th, 9th day, their infectivity actually comes down, and the test rate also will come down after that. Now, coming to the category C group of patients, they come to you many a time when the community spread is at its nadir, as we see today. We see patients either there's remained and in some peripheral hospital or first line treatment centers or at home. They develop cough, fever. They go on having these symptoms for 5 to 7 days. Suddenly they desaturate. These group of patients usually will have a downhill course. By around 3 to 6 days, you should start treatment since the onset of symptoms. Late treatment, whatever is available, may not work. When I say that, we don't have much treatment available, but still the mainstay of treatment is supportive treatment. The supportive treatment include admission and oxygenation. Then you can give assisted ventilation in the form of a non-invasive ventilation, or some patients who require mechanical ventilation. So with the onset of symptoms of cough, fever, and the first nasty sign of desaturation, the first week of illness itself, you have to start antivirals like remdesivir. So early institution during the first week of escalation of symptoms with these medications, which are not specific but is being used on compassionate ground, will definitely help you in a group of patients. But as I told you earlier, we do not know why some patients' immune system, reacts in a very erratic way, so that there is absolutely an onslaught of inflammatory soup and the cytokine release, which affects multiple organs. They usually have, when you look at the liver function test, you will find that it's COVID. The enzymes are raised, SGPT is to 400, 500. So there is an entity called COVID hepatitis. Same time, the renal functions will come worsen, and you can see an acute kidney injury. Many patients develop fulminant myocarditis. So once they develop fulminant myocarditis, as evidenced by the echo tropi elevation, so all patients admitted in the hospital has to be closely monitored for development of myocarditis. They should invariably have an echo, baseline echo. They should always have a tropi. So we have a 24-hour cardiology coverage wherein all patients who come with moderate ARDS to advanced significant ARDS patients with pneumonia, and all young patients with patches in the lung will invariably have a baseline tropi and an echo and an ECG, and will monitor. If the patient develops some untoward symptoms like unexplained tachycardia, which cannot be explained with the level of desaturation, and again we'll have to repeat the tropi. If the initial tropi is borderline, then you have to repeat it every 12 hours to make sure that these patients are not developing fulminant myocarditis. Fulminant myocarditis is one of the most important causes of death in COVID pneumonia, if it is not due to a coronary event or a refractory hypoxemic ARDS. So early initiation of treatment, early recognition of symptoms in the ward, and early assessment of progression of the illness. This is also very, very important. So the strategy that we use is that if a patient is admitted with category B or category C symptoms sufficiently early in the first week, and if you know that this patient is oxygen dependent and desaturating, then he qualifies for steroid. Steroid is a drug of choice for anyone who has a patch in the lung, plus they are oxygen dependent and they require at least 4 liters of oxygen via nasal prong to maintain their saturation of above 94. Then this group of patients will usually respond to steroids. So the famous recovery trial from UK actually, which has looked at the largest number of clinical patients with COVID significant symptoms, over 9,000 patients has been enrolled in this study, and they found that early institution of steroids in those patients with a pneumonic patch on the X-ray and also who require at least 4 liters of oxygen via nasal prong is a candidate who would respond to steroids and probably prevent the progression to respiratory failure and landing up on mechanical ventilators. So we use steroids. We use remdesivir in the first week of presentations. And antibiotics, usually we use it as a supportive measure to prevent the secondary bacterial infection. That is not very important. So the clinical setting, two things I have told you. The third one is about the unpredictability of this disease. Unpredictable. The patient looks apparently normal. The X-ray remains moderate ARDS or they continue to worsen. This is one group of patients. The second group of patients are the one, they present with moderate ARDS. On X-ray, you see the classical bilateral peripheral patches and ground glassing, which is classically lingering around the lateral thoracic wall, most of the time occurring at the lower lobes. So in the earlier part of COVID pandemic, my hospital was the first one to do a CT chest. And initially, the patient who had, we could see a patch in the lateral aspect of right lower lobe. We could not see much on the X-ray, but the patient had a disproportionate desaturation. So anybody who is having a disproportionate desaturation, X-ray may not always show bilateral significant patches. In this group of patients, you have to subject these patients with CT chest. And the high resolution CT will significantly show you that there are abundance of lesions starting from apex down to the base bilateral, and in another 48 to 72 hours the lesion will increase fast. So the progression of this disease, once it starts, once you see a pneumonic patch on the 4th day or 5th day of symptoms of increasing dyspnea and desaturation, you take the X-ray after 2 days, you will see that the whole lung is whited out. So this is the fastest progression, and once they reach at that level, then they cannot maintain saturation in room air. So you put the patient on NIV. The moment you remove the mask, they desaturate. This group of patients will be hypoxemic, and they will continue to be in hypoxemic respiratory failure for 3 weeks, 4 weeks, and suddenly they may crash and they die of other organ injury. And other group of patients are the one who recover. Apparently they recover, like their oxygen requirement come down. Their oxygen requirement come down, but you cannot remove the mask or oxygen. And they go on like this for 4 to 6 weeks. A very small percentage of patients go in for irreversible hypoxemic respiratory failure, which may even warrant for a lung transplantation. We don't have any experience on lung transplantation, but reports have shown that a minority of patients in whom they can afford lung transplantation, it might work. But this is in the subacute stage. What I am talking about, the acute clinical setting. In the acute clinical setting, the most important things are early recognition of symptoms. That is very important. Close monitoring every 12 to 24 hours so that you can shift the patient from the ward to the ICU. So once you admit a patient with category B symptoms in the ward, because we cannot admit all category B patients in ICU because ICU beds are limited. Those patients who require admission in the ward should be closely monitored. The moment they develop the first episode of desaturation, they should be shifted to ICU. So what are the risk stratification clinically that we do is you monitor the saturation. So the ominous signs are when the saturation drops from the baseline of 96 or 97 on admission to 93, that is a first warning sign. So anyone who drops to 93 is a candidate to be transferred to ICU for further close monitoring, number one. Number two, any patient who is having a tachycardia of more than 130 should be shifted to ICU. That's the second risk stratification. The third clinical situation wherein you have to shift the patient when the patient's respiratory rate is more than 30. So usually 25 to 29, you may keep in the ward, but it's not safe. So any patient who has a tachypnea and goes about 30 should go to the ICU. And the first line of treatment should be with FiO to 100% with non-invasive ventilation, because once you intubate, things may not always be in your control and patient may crash. So try to maintain and stabilize the patients on NAV. You can do a frequent arterial blood gases. Now, look at the pulmonary embolism parameters. So what are the things in the early clinical setting that we should look at? Any patient who is admitted with significant symptoms should have a baseline CBC. The complete blood count alone is required for you to actually assess the prognosis of this patient. The temporal profile of the patient can easily be assessed by looking at the complete blood count. Usually the total count will be low, and there is something called neutrophil lymphocyte ratio. The normal neutrophil lymphocyte ratio is less than 3.5. And if the neutrophil lymphocyte ratio is more than 3.5, that is an indication of worsening. And anybody who is having a neutrophil lymphocyte ratio of more than 5.5 is significantly telling you that this patient will worsen, go in for ARDs, and probably die. So how do you look at neutrophil lymphocyte ratio? It's very easy. Most of the time you will find that 85 to 90% are neutrophils, only 10% lymphocytes. So normal lymphocytes is around 30 to 40%. So lymphopenia in this complete blood count is a very bad prognostic sign. And if the absolute lymphocyte count is less than 800, you can be sure that this patient will develop a cytokine storm and they will go into ventilator and probably they die. So upfront, if you see, despite significant symptoms and a pneumonic patch, your patient is stabilized, and if a neutrophil lymphocyte ratio is maintaining less than 3.5 or just 3.5, then you can be happy that, okay, this patient may not worsen. But upfront, if you see a patient whose neutrophil lymphocyte ratio is more than 3.5, or absolute, or the lymphocyte alone is 10 to 12%, less than 10%. These are the group of patients who would worsen with significant lymphopenia. Lymphopenia indicates increased immune dysregulation when cytokine storm release has occurred. And if you look at the patches which is progressing on the X-ray and CT, that also correlates with the kind of cytokine storm that is going on. The patch that you see in ARDS in other conditions are not the one that is being represented in COVID-19. In COVID-19, this virus most probably replaces the heme in the hemoglobin, and it is the displaced heme that you see on the lateral aspect as ground glassing on the CT scan. So it is not exactly the alveolar exudate. There is alveolar exudate, there is increased leakage, and at the same time, there is probably a lot of heme exudation, and there are a lot of microvascular thrombosis. Micropulmonary vascular thrombosis, not the classical P that we are talking about, where you can see the macrovascular arteries, arterial territories are occluded, as evidenced by the contrast filling defects. But you probably won't see any of those if you do a contrast enhanced angio-CTPA, but they will have a micro angiopathies. So this hypercoagulable state is one thing which actually hastens the death in COVID-19 patients. That is why we now, it is a standard practice that anticoagulation should be the mainstay of treatment in all patients who shows an increasing D dimer, who shows significant moderate ARDS and worsening on ventilation and increased requirement of oxygen. So all patients who have moderate ARDS, having a very bad neutrophil lymphocyte ratio, increased D dimer, increased CRP, these group of patients should be on therapeutic dose of heparin, therapeutic dose of anticoagulation. We usually use enoxaparin, and on discharge, all those patients who are on enoxaparin should receive another 2 to 3 weeks of oral anticoagulant, something like apixaban. This is because I have told you earlier, the hypercoagulable state exists long after the COVID test becomes negative. So this long post-COVID syndromes and coronary events and other vascular events can only be prevented by giving anticoagulation at discharge. This is a very, very important aspect. That is why you would see some patients dying on discharge at home or in other care centers. Now, for cytokine storm, once they develop, I have told you there is nothing much that we can do, but we can definitely try IL-6 antagonist like tocilizumab. And some, if you start early and if the patient is young, then probably you will be able to save many patients. We have saved many young patients. Now, the comorbidities that is seen along with the COVID-19 infection is one important thing that actually caused a lot of mortality in India, in Kerala also. And the single most risk factor is a morbid obesity. If a patient with COVID positivity, with symptoms, B or C symptoms, if he is obese, Morbid obesity alone is the single most independent risk factor for high mortality. So this is very important. And an uncontrolled diabetes, and those patients who come with a diabetic ketoacidosis at presentation can also worsen and die. So these are the two most important. Another group that we see is those patients who have had actually a CABG status or a post-angioplasty status. These three group of patients. Then a large chunk of chronic kidney disease patients. These are the group of patients who usually succumb fast. But then that will not answer our question why young patients die without any comorbidities. We don't have any answer to it. Most probably a overwhelming cytokine storm and dysregulated immune regulation, which is the reason for death among young patients without any comorbidities. I think I have covered most of the clinical aspects, how it progresses, how you monitor such patients, and why some people die, why 80% improve. And there are so many things which needs to be elucidated in future. A lot of research is going on. Probably this particular disease had seen billions of publications from all over the world, an unprecedented disease where so far in the history of medicine, the last 100 years, not this much of publication has come. But then we could not actually look at what exactly is the reason why this disease takes away life in some, and in some others are protected. Having said that, our innate immunity from countries like India, sub-Saharan African countries, we probably have been living with a kind of low-level hygiene, exposed to large number of parasitic infections and frequent viral infections and malarias and other things. Maybe that is the reason why if you look at the mortality in India is even now very low compared to the, the mammoth population and the overcrowding, the density. Still, you look at the Dharavi, Mumbai, we expected a huge explosion of that. That did not happen. So probably the hygiene hypothesis is now coming back, saying that we, as sub-Saharan African countries and Indian people, have been exposed to a lot of other infections. That's why I said, what is important is your cell-mediated immunity. It is not the humoral response. So if the moment a virus gets, it has to enter into inside your cell, the intracellular killing should occur. This is cell-mediated driven, and it is not humoral medium. So don't expect the herd immunity to protect you. It will not protect you. It is dangerous. We know that only 5% of the population, I think the publication has come last week, around 5% or so. The study came from Spain, which has shown that only 5% has shown herd immunity. 95% did not. So please never depend on herd immunity. It will never come. You have to protect yourself. The only way is to avoid by any means this infection. And we do not know the long-term effects of this infection. What will happen after 1 year, 2 years? Many patients have got COVID encephalopathy. I forgot to tell you. They have a delirium, non-responsive, not much of pneumonia, but they are delirious. This is a very bad sign, they die. So COVID encephalitis and COVID encephalopathy is known. Neurological disorders are known. And increased incidence of Parkinsonism among those patients who never had anything, young patients who had a diagnosis of COVID pneumonia 6 weeks back, after 2 months coming with Parkinsonism. So there are so many extra pulmonary manifestations. I could have shown you those slides, but unfortunately my microphone has ditched me. Anyway, I did not want to show all the slides, but I had 5 or 6 slides only. I thought I will just tell you. But I always feel comfortable talking to you in a webinar. Actually, you should talk. When you look at the slide, we cannot concentrate both unless you are attending face to face. So I don't know whether I have done justice to this program, and I am free to take up your questions if there is any. Thank you all the organizers, and thank you for a patient hearing, for giving me this.
Thank you, Dr. Fatauddin. We are short of time, but still I would say that it's a very good clinical, concise clinical perspective given to all radiologists. Many factors which you have mentioned, I think the radiologists, we just image it, but these things are really informative for us. Thank you for that. It looks like a class in our PG days or MBBS days. Thank you. Now, now we'll go to our next talk of this today. That's the COVID care for the patients by radiographers. And I think Rajesh will link us from Kottayam, and he'll be talking on the role of radiographers in COVID-19 patients. Over to Rajesh.
Audible, sir? Am I audible, sir?
Yeah, you're audible.
Okay, thank you, sir.
Rajesh?
Yes, sir. I'm starting.
Oh, okay, you start.
Hello? Hello?
You're audible.
Okay, okay, sir. First of all, thanks to Dr. Jayasree and the persons from Trivandrum City Chapter Radiology Club for this opportunity. Good morning to all. We all are here in this classroom from the war front of COVID-19. I am Rajesh KM, Finance Secretary of Indian Society of Radiographers and working as a radiographer in MCH Kottayam. We pay our tributes to this great man, William Conrad Röntgen, on this 125th anniversary of discovery of X-rays. And my presentation is regarding COVID-19 imaging, care, support, and challenges of radiographers. In this 125th anniversary, the world itself is facing with the pandemic COVID-19. So our scenario and our talk changes to the same portion about this imaging on COVID-19. COVID-19 is a serious challenge to radiology and imaging, which is unpredicted in recent history. We are promoting judicious use of imaging to facilitate and maximize the quality of patient care. Why radiology? Because the length changes caused by COVID-19 is best demonstrated and analyzed by radiological imaging. Technologists or radiographers provide a good images for correct and best decision for clinicians and radiologists. So, radiologists and radiographers play a critical role in prevention, control, and treatment of COVID-19. Then we have to check about the international scenario. Various imaging modalities being used for the management of COVID-19 in China. They use chest radiography, X-rays, CT chest, plain, angios, and HRCT, USG for DVT and chest imaging. And they even use PET-CT to provide supplementary information regarding the CA patients. But American College of Radiology is against using CT as a screening tool. They advise that symptomatic patients with clinical indications should undergo CT. But local resources are always the factors in decision making. We all are aware with that. The studies reveal that chest radiography shows no abnormalities in early stage COVID-19. So there is no use of chest radiography as a screening tool. But the CT shows early changes even if the RT-PCR test is negative. So CT can be used as a screening tool, but there is a problem regarding cost and risk of the CT. Chest X-ray can be used as a screening tool for who are not allowed to transfer to CT. PET-CT is used for supplementary information only if it is necessary. Our scenario, we are using X-ray and CT only for the imaging of COVID-19 patients. And this is the images for X-ray and CT scan. Most probably we are using portable X-rays, and the other one is a CT room, which is ready for to receive a COVID-19 patient. An X-ray, we have go through two types of X-rays, room X-ray and portable X-ray. For room X-ray, we need a dedicated room for deal with the COVID-19 patients, and transportation also is another problem. The patient is viable for transportation, and we need a green channel for the transportation of COVID-19 patients. And regarding portable X-rays, there is two problems. One is the radiation risk, and next is the quality of image. Portable X-ray in ICUs, we are coming through different type of difficulties on imaging patients in ICU with a portable X-ray. One is the obese patient, and the patients are connected to ventilators and connected to many other monitoring devices. There is a limitation of machine movement, portable machine movement within the ICU, and the lifting of the patient, there is a high chance of aerosol production and infection. And we have to attend many patients in a single shift in different ICUs. So we are in close contact with patients, and it is more than 20 minutes for patients in ICU. But even if the government or authorities don't consider radiographers uh, as a challenge in their protocol, that is an issue. In CT scan, we need a dedicated COVID scanner if it is available. Otherwise, as Madam said, we have to fix the time after routine patients. And the patient has to stay more time for plain and contrast study if needed, and angiography is needed. Pulmonary angiography is usually done for COVID patients with elevated D-dimer. And most of the patients came for CT scan are ventilator patients. So they are unconscious and restless patients also coming for CT. The challenges are shifting them from the ambulance to CT table, because there is no bystanders are here for shifting and helping. And the radiographer himself should help for the shifting, and the handling of the patient is also a problem. There should be a chance of aerosol production. And the general challenges are decontamination of the equipment and room, and the delay between examinations and personal protection of the staff. For decontamination, we are usually using hydrogen peroxide vapor or ultraviolet light are easy to use, but sodium, we have to avoid carpets, textiles, curtains, furniture with upholstery in the room dealing with the COVID-19 patients. The linen, paper, plastic extra should be used, should be discarded at that time. Detector and cassette should be whipped twice before storage with the appropriate disinfectant solution. It is sometimes it may be provided by the company, and in an alcohol with more than 75% of alcohol content is very good for cleaning and whipping. And personal protection, use of proper PPE and the size of PPE and availability of PPE are the issues. PPE is not available in non-COVID area, so we have to deal with the mask, gloves, and mask and gloves. And the cleaning of the area, floor, equipment, and the door handles after each patient is an issue. Care. We have to, these are the points of care. One is the position of the patient. The position of the patient is according to the examination carried out, which is requested, and the exposure factors should be correctly arranged. The placement of cassette and detector is to be correct. The ventilator tubings and other lines should be take care of, because there is a chance of disconnection on tubings. Movement and transportation of the patient, and the portable X-ray unit and the CT table also need care, because there is also a chance of disconnecting ventilator tubings.
Hello, Mr. Rajesh. Sorry to interrupt. Rajesh, can you just click the screen sharing option? Actually, your slides are not seen.
Okay, okay, sir, 1 minute.
Share your screen ഒരു ഓപ്ഷൻ ഉണ്ടാവില്ല.
Yes. Is it okay now, sir? Hello?
Yes, yes, yes.
Right.
It's okay. It's okay now. Please continue, sir. Please continue.
Okay, okay, sir. So the personal protection, which I said now, and the points of care are position of the patient and correct exposure factors, placement of the cassette and detector according to the request, which imaging we are going to do, and the ventilator tubings and other lines, and the movement and transportation of the portable X-ray machine or CT table, because the ventilator tubing, there is a chance of disconnection and aerosol contamination there. And safety practice. Portable machines should be stored in an area outside the contaminated area, which helps us to reduce the cross-contamination and infection. The detector or cassette should be double bagged within a polythene bag, and a negative pressure room is advised, because the negative pressure rooms protect the outside from the aerosol produced within the room, and HEPA filters are used for purifying the air within the room, and a sufficient shutdown period from 1 to 2 hours is required to cooling off time, and the cleaning between patients is also an important thing. Special uniforms are recommended for the staff attending the patients to reduce the cross contamination. Practical difficulties in COVID area. The availability of dedicated equipment is a problem. If dedicated equipment is available for imaging of COVID patient, it is best advised. The quality of the equipment is another problem. The collimation and lighting is an issue. The quality of the equipment are most of the medical colleges or government institutions, we are used the manual portable X-ray. If a DR, a digital portable X-ray or retrofit X-ray, portable X-ray unit is available, it should reduce the chance of cross contamination, because there is no need of transporting cassettes from ICU to the processing room, and the fast imaging is possible with the new modalities of machines. And the collimation and lighting is another issue, because in most of the ICUs and COVID wards, which is set immediately, there is a lot of light from outside, and the bright light is given in the ICUs. So we have to very difficulty to find out our collimation light and centering of X-ray. And the next problem in practical difficulty is regarding the power supply. We need a power point more than 16 amperes. 20 ampere is advised, but the availability of power supply or power plug is very less within the ICU or ward. And we have to overcome this problem with the use of an extension board and violation of SOP. SOP is the standard operating protocol. We made a standard operating protocol for all imaging, that is imaging inside the department, imaging with using portable X-rays, and imaging inside CT room or MRI room. And the cleaning is another issue we have to come across. Practical difficulties in non-COVID areas. In non-COVID areas, the main problem is all the patients are coming without COVID test. So we have to consider all of them as a positive patient. But PPE is not available, full PPE is not available in non-COVID areas. So we have to deal the patient only with the gloves and mask. And there are restless patients are there, and unconscious patients or unknown patients are there. So we have no chance to find out their history. So they are coming from an area of COVID, or they have a primary or secondary contact with the COVID patients. These all are unknown to us. So we should handle all of them as a positive patient. And the cleaning is another problem. Cleaning after each patient is advised, but it is also not practically done in our institute. And so there is a chance of cross contamination between patients. And as we are handling the unconscious and less stressed patients, we need more time to deal with the patient. We are touching with the patient, and we are in a circumstances to high aerosol generation. But we are not considered as a risk category. Radiographers or radiologists are not considered as a risk category in our protocol. Other challenges: the increase in number of volume of patients and number of examination, and there is some studies are there. They are not related with COVID, but they forced us to do the problems at that time or within this COVID positive time also. And the patients, post-COVID patient imaging is also increased the number of studies. And in remote areas and first-line COVID centers, there is no screening or review of requests or images with radiologists. So there is a increased number of imaging in that type of institute. But in medical colleges, we are managed with our radiologist. The number of imaging should be controlled, and the absence of protocol for radiological investigation of COVID patients. So I think there is no protocol for this, because in every center they are using their own type. Some centers they doing chest X-ray for all patients, but in medical colleges and other institute having the service of radiologist, the protocol is there, and we are using the standard operation protocol. There is a non-availability of online image and patient records. So usually there is an issue of repeated studies, because the patient imaging is not available for the patient, or it is within the COVID area, and it cannot be get back. And patient records are also not available when they are shifting from first-line treatment center to medical colleges. So there is a need of repeating the studies. And radiation monitoring is also not possible, because in first-line treatment centers and other remote centers, the radiographers working are temporarily taken for this COVID as COVID variants. So they are not allowed, or the radiation monitoring devices are not given for them. So radiation monitoring is not possible. They do not have the TLD badges, because it should take around 6 months to process a TLD application now with AERB. Physical challenges. Use of lead apron with PP is a physical challenge that radiographers undergo. Movement of the machine use with this PPE is another problem. So around 5 kilogram weighted lead apron over PPE, and moving a machine of 500 kilogram within the ICU is definitely an issue. The patient handling is another issue. Patient in ICU with a tracheostomy is also a problem. The patients are, and the restless patients and non-bystander patients also to be handled. The tracheostomy patients, regarding them, there is a high chance of aerosol production and contamination, and lack of facilities, and there is a reduced vision within the PPE kit, also a physical considered as a physical challenge of radiographers. And mental challenges. As a social being, repeated quarantine and approach of society should affect the mental health of a radiographer. The increased workload and consideration of family also affect his mental condition. The other thing is radiation risk. We all know that portable X-ray produce much of radiation. So there is a radiation risk regarding portable X-ray. And another thing is portable X-ray in ward. Portable X-ray in ward is not only affect the radiographer or patient, because a portable X-ray taken in a ward of 30 to 40 patients, the X-ray risk is also to the neighboring patients. And the repeated studies increase the radiation risk. Use of lead apron over thyroid shield is highly recommended to reduce the radiation risk. But my colleagues from the remote centers said that they are not allowed to use lead apron, even lead apron, because cleaning of lead apron after using in isolation is a big problem. So they won't allow to use lead apron. And the absence of monitoring, as I said, is another problem, because TLD monitoring badges are not issued for these temporary workers in remote centers. As in the figure, you can see that the portable there is a portable X-ray using lead apron around 5 kilogram. It is above the PP, and we have using one plastic apron above this lead apron to avoid cross contamination. So how we handled through? Then we handled these difficulties through proper safety measures and standard operating protocols. And we use pair system, that is buddy system of 2 radiographers, which for X-ray and CT. For X-ray, one radiographer is on PPE and doing the X-ray. The other one is used to handle the image, processing the detector or cassettes. And in CT also, one is on the console and the other is dealing with the patient, ensuring good practice to limit cross-contamination, strict personal hygiene and safe distancing, not only in the department but also in our houses and society also, and giving maximum support to the staff who is on duty, and keeping good relationship with other department. Here I am showing you some SOPs made for this is the standard operation protocol we are using for CT. There is 3 parts. One is receiving the request, and the other is preparation of the CT room, and the third one is a technique. And regarding this, patient request must contain the following details: name, age, sex, and ID number, and the part of the examination with the signature of medical officer. And the radiographer must inform the exact time of the examination to the concerned nurse or physician to reduce the delay. And preparation of the CT room: remove all movable things like pressure injector, chair, lead apron, crash cart, etc. from the room. Cover all the immovable items like ECG monitor with the polythene sheets before the patient enters into the room. Centralized oxygen connection and oxygen cylinder kept ready. Switch off AC and seal all AC ducts and just before the scan. Technique: 2 radiographers will be donned, one in the console room and the other for the positioning of the patient. The first radiographer will receive the patient and will position the patient, while second radiographer will sit inside the CT console room. After positioning, the first radiographer will stay outside the room with the clinical team. Now, it is the question, why the second radiographer also be done? Because if the patient inside the gantry has an emergency, the radiographer inside the console only should know that, and he should need to go to the patient for his assistance. After the second radiographer will do the scan. After scan, the second radiographer will allow the clinical team to enter the console room. Push the study to the pack system if it is available. Print films or CD according to the procedure of the hospital. The first radiographer will help to remove the patient from CT room and supervise the cleaning staff to do the cleaning of the room and the machine. Shut down the machine and turn off the power of the machine should be cleaned in accordance with the concerned company cleaning protocols. Next is the standard operation protocol with a room X-ray. Do not take X-rays of COVID active or positive patients from the department unless it is unavoidable. Patients should be masked throughout the transport and in the radiology department if the patient is positive or suspected one. And receiving the request, patient request must contain the following details as in CT: name, age, sex, ID number, and part to be the examined, and signature of the medical officer. Radiographer must inform the exact time as in the CT for the protocol. Yes, sir. Sir, please tell me.
Slides are not moving. Your slides are not moving.
Sir, it is about the standard operation protocol, sir.
Okay.
So just I am reading because it's a PDF file. Radiographer must inform the exact timing, and as in the CT, we have to cover all the things. And the third one, is a standard operation protocol for portable X-ray. There is also a workflow provide dedicated portable X-ray machine for ICU, mobile X-ray machine suitable for extension boards. 2 radiographers should be go for taking the X-rays. Arrangements to be made to take X-ray of all patients. Take X-ray suspected patients first and confirm their name, ID, etc. to avoid a mixing. Inform the ward staff to provide a mask for every patient. Radiographers should wear a radio protective lead apron above the below the PPE kit or above the PPE kit according to it. If it is above, we have to wear a disposable gown over the lead apron. One radiographer should don the PPE kit and do the things. And the other things I have discussed earlier. So this is about the standard operation protocol. The standard operation protocol should be maintained for every examination within the department and for the portable patients and in CT or MRI. And pair system is to be used, and we are ensuring good practice to limit cross contamination by this standard operation protocol. And summing up, the technologists are under high risk. Emphasized physical and mental fatigue during this COVID, but we are ready to fight for flattening the curve and proud to be a COVID warrior. And the last, not least, we are paying our tributes to this lady, Anna Bertha Ludwig, the lady behind the man. And thanks to all, on behalf of all radiographers and ISRT, Indian Society of Radiographers and Technologists, Kerala chapter. Thanks to all.